The final paper in this session is going to be presented by Dr. Stephen Mehl from Texas Children's Hospital. The paper is titled Disparities in Pediatric Surgery Telehealth Access During the COVID-19 Pandemic.
Hi, thank you for the opportunity to present our work today. We have no disclosures. The COVID pandemic resulted in a significant increase in the use of telehealth with regards to outpatient surgical encounters. With our group, we had wide-scale implementation of telehealth due to the pandemic at the beginning of March 2020, with our previous experience primarily limited to post-operative checks in the chest wall malformation clinic with few providers using it regularly. As telehealth has continued to gain acceptance in different healthcare settings, there have been concerns about some patients' ability to actually complete telehealth visits. For example, previous studies have identified that a patient's ability to successfully complete these visits varies based on their socioeconomic status, primary spoken language, and then also access to smart devices. So we had concerns that with our wide-scale implementation of telehealth in response to the pandemic, that we might have disparities in terms of access to surgical care. With these concerns in mind, we had two primary objectives. First, to characterize our use of telehealth prior to and also after wide-scale implementation, and second, to identify patient characteristics that were associated with increased rates of missed telehealth visits relative to in-person visits. Based on previous studies, we hypothesized that specific patient populations would have significantly increased rates of missed telehealth visits, and then significant findings from this study would allow us to develop targeted interventions for these at-risk patients. So we performed a cross-sectional study of all outpatient surgical encounters from January to May 2020, which included 6,800 surgical encounters. This study period was divided into a pre- and post-telehealth period with based off if the encounter occurred before or after March 1st, 2020. Our primary outcome evaluated was the final status of the encounter, defined as a completed visit or a missed visit, which included both no-show and also canceled visits. And our primary exposures were the patient's health insurance, self-identified race, and the patient's home address. So this first slide will show the transition of telehealth following March 1st. Prior to March 1st, we had only completed 12 telehealth visits in January and February 2020. Following March 1st, we had about 90 visits completed per week, which totaled almost 1,000 telehealth visits. This represented an 80-fold increase in telehealth between the two time periods. This next graph shows the proportion of visits that were missed versus completed for telehealth following March 1st. As you can see with the red bars, about 20 to 25% of our telehealth visits were consistently missed per week. And when performing analysis for the specific patient characteristics that were associated with missed telehealth visits versus in-person visits, we identified that those patients who self-identified as Black were more likely to miss a telehealth visit, and those with public health insurance were also significantly more likely to miss a telehealth visit. We also analyzed ethnicity and primary spoken language, but these were not significantly different between the two cohorts. This next map shows the distribution of COVID-19 cases in the city of Houston at the end of April 2020, with dark blue showing higher frequencies of COVID-19 infections, and a picture of TCH to show in reference to the rest of the city of Houston. And then interestingly, when we viewed the specific zip codes that had the highest frequency of missed telehealth encounters, it appeared to correlate with zip codes that also had higher frequencies of COVID-19 infections in the household. So this would suggest that those patients that might benefit the most from telehealth were actually missing the visits. And in conclusion, wide-scale implementation of telehealth might have exacerbated disparities for surgical care. And then specifically for our population, we had identified that patients who self-identified as Black and those with public health insurance were significantly more likely to miss their telehealth visits, and that certain zip codes had both high frequencies of missed visits and also COVID-19 infections. Similar analysis could be performed by other hospital systems to really identify these characteristics and potentially create targeted interventions to counter these disparities. Future studies would need to perform qualitative research to better understand the specific barriers to telehealth, and also to perform more robust geographic analysis even at the neighborhood level to identify the neighborhoods where these missed encounters are occurring. Thank you very much. I can take any questions at this time.
This paper is open for discussion.
Hi, Brian Coakley, New York. Really good study. I was just curious about two things. One, did you make any efforts to quantify patient satisfaction with their telehealth visits versus on the inpatient encounters? Because I think the missed visits is one part of the story, but it's certainly not the only part. Mm-hmm. Then the other question is, I'm curious what you do for language translation services in your telehealth visits. Was it, did you have an in-person translator next to the physician, or was there an electronic translator built into the format, or did you use a separate format altogether?
Of course, thank you very much for those two questions. With regards to the first one, it wasn't the data for this specific time period, but we did evaluate press Gini scores throughout 2021, and we had identified no difference between in-person versus telehealth visits with regards to press Gini scores. So satisfaction appears to be similar with those two settings. And with regards to your second question, I apologize, I did forget the second question. Apologize. Interpreters, oh yes. With
interpretation services, how
yes.
did you use that in your telehealth?
And with that, there is a link whenever a patient logs on where there is a remote interpreter that translates everything for the patient. So it's not next to the physician, but it's a video link with them on as well.
Do you have data on the reason for the missed visits, and do you have data on the type of visits that were missed, for example, new versus returns versus post-ops?
Yes, of course. The whole purpose of doing this was to inform future research efforts. So in response to this, we had created a multidisciplinary group that involved pediatric surgeons, telehealth leadership, and also qualitative researchers. So with the help of the qualitative researchers, we were able to do semi-structured interviews to identify why patients were missing visits, and the main reason appeared to be poor Wi-Fi connections from those patients that we were able to interview. So that appears to be the more granular reason why they were missing it. And then in terms of what were the specific outpatient visits that were being linked to the missed visits, we were not able to see any significant difference between different outpatient visits. This cohort includes both new patients and also old patients that were coming back after seeing us for a first visit.
Hi, Ruth from UCSF. Great presentation. Thank you for your work. I am working on something similar, so I have a question about your methodology. So when you were looking at the data by visit, did you consider also looking at like patient level data? And kind of what was your thought process with that? And I think the second part of that question is, when you chose to do visit level data, was there a way to track how many of those were rescheduled instead of just canceled?
Is it by patient level data? What exactly are you referring to there? What variables?
I presume that these visits are not different individual patients and their patients coming back. I don't know if maybe I misunderstood that.
Yes, so these were all of first encounters for them in terms of it was their first time during this time period to come and see us. And then with regards to rescheduling, we did not have that data with this cohort.
Thank you.
Hi, Bevan Mayberry, Upperman, UCLA and VA. So this is a really great study, especially looking at surgical visits. There are a couple of things that I want to ask you, did you do? With regard to missed visits, could you, not necessarily miss, but could you tell if a visit got changed from a telemedicine, say a doximity visit or visual visit, into a telephone visit because the patient couldn't get on Wi-Fi, or they couldn't reach the patient, or they knew there was some connection problem? So that's the first one. And the second is, for the people who could not be reached, do you know if it was a adult who had children in the home? Because many patients who had kids in their home would not do their visits if their kids needed the phone, the computer, or the pad for school. So I just want you to consider that when dealing with adults, and then also with dealing with children having visits where their parents have to be present, but the kid also had to be at school.
Thank you for those questions. And whenever we had stratified these as missed visits, the only granularity, some of the data we could use is whether it was a no-show versus a canceled, and there was no other information about why it was canceled or if it was rescheduled as an in-person visit. So we were not able to use that more granular data, but in our qualitative analysis, with regards to your second question, that did not seem to be a theme that consistently came up. It was primarily that there was a poor Wi-Fi connection. With that, we had performed an interview for 20 patients, so that it might have been that our sample was too small to increase and to capture that theme for the larger population. So it would be worth it to continue these interviews to see if that theme emerges. So thank you for that insight.
I assume from your conclusions that your intent is not to limit or abandon telehealth, but rather to fix telehealth. Because as we learned about earlier today, clearly there are benefits to some populations in terms of cost, in terms of travel, in terms of missed time from work, that are all beneficial when it comes to telehealth.
Yeah, I think that as we move out of the COVID-19 pandemic, we realize that telehealth is here to stay. And I think that as we implement it more often, we have to ask questions and ensure that all of our patients are still getting the same access to care that they would if we were only using all the in-person visits. So we hoped to share this analysis so that it could be reperformed in other hospital systems so that they could identify those patients that are consistently being missed, and then create targeted interventions for those patients in terms of qualitative analyses and the more robust geospatial analysis to really identify the neighborhoods where these missed visits are occurring.
Great. We have one more question in the back.
Hi, Aaron Jensen. Just to follow up on that fixing the problem implementation piece. We've had great success, and we're really blessed with MAs in our clinic who are bilingual. We have them contact the family 15 minutes before the visit and talk them through, like over the phone, how to get onto Zoom, how to log in, how to access the platform. Because we found that families with very low healthcare literacy and technology literacy and don't speak English as their primary language, those are the families that weren't showing up for telehealth. So we have engaged our bilingual MAs to just get them on the Zoom. And it's fantastic how it works and how happy the families are that you take just a little extra effort to help them navigate the technology. So just perhaps with a little extra effort, we can do this, but it does take investment of time by all of us.
Right, yes, thank you. And then one other thing that we had talked about doing is creating then a readiness checklist. So then if a child comes in for surgery, then at the time of discharge, we could create a readiness checklist that could see if the family does have the resources to complete the telehealth visit. And if they do not, we could help them download the app, make sure that they understand the different components of the app so that they can complete the visit. And if they are not able to get those resources, then we could ask them to come in for the in-person visit to make sure that they don't miss their post-operative visit. So another kind of in the similar realm of helping families become more comfortable with the technology.
Thank you.
Thank you.
Thank you.